this year we are conducting OSCE as a teaching program rather than the case discussions. It is being well appreciated not only by the postgraduate but faculties as well. From last 2 years, OSCE is being asked for, I mean, as an exam for MD exam also. So to prepare the OSCE standard OSCE questions, faculties also need training. So this is very much helpful for faculties as well. So today's program, without much delay, we'll start the program. I once again welcome you all on behalf of IAP Kozhikode and wish this program all the success and wish all a happy learning. Thank you. I welcome Riya sir for telling a few words.
Thank you, Dr. Rajesh. I just want to express my sincere gratitude to the team headed by Mohandas sir, and this time the Cochin team headed by Rajesh sir, and also my own teacher and my the dear brother Sankar sir, as well as my Idiki mate Gireesh for this wonderful session. And I think genetics questions and genetic cases are always a very interesting piece of information and teaching in all areas. So I wish this will be a very exciting session. I wish all the best and we will go for the academic part. Thank you.
Mohandas sir, straight away, shall we start or any other?
If another question, sir, want to say a few words?
Another question, sir, few words from you.
Sir, muted.
Sir, muted.
Very good evening, respected state president, all the senior faculty members, my colleagues, dear friends and students. Because recently we had MD examination, the performance regarding OSCE is not good as DNB students because we got DNB examination also. Somehow our MD students are not well, means they are somehow lag behind the DNB. I am not saying, I am not comparing. So I think our MD students require more and more training in OSCE examination. Of course, for faculty also should have some exposure. I wish the program was success. Thank you. Over to Rajesh.
Sir, shall we start?
I think Dr. Shankar
sir.
will start the session. Shankar, the professor of genetics in SIT Hospital, a well-known geneticist of Kerala.
Okay. Thank you, Dr. Mohandas and entire team Kozhikode as well as the team IAP Kerala for giving me the opportunity for discussing some OSCE questions on genetics during this PG club session. I think so many PGs have attended, so many senior faculties are there, Purushothaman sir, Sulfikar sir I have seen, Darli, Virendra Kumar, so many people are there. Okay. So we have divided the entire three into myself, Mohandas and Gireesh into three parts, three questions each. One will be on monogenic disorders and genetic testing. Second is on pedigree and third is on counseling and Down syndrome. So I will be first start with the monogenic disorders and genetic testing. And I think I will, without wasting time, I will go with the questions. It is visible? I think it is visible.
Yes. Yes.
Visible. Okay. Okay. So as a standard OSCE, I think it is in OSCE during the online session. I don't know whether I can do like that because I am doing by question one by one. So that 5 questions will be there. Sub questions will be 1 to 5 for 5 marks. Sometimes in DNB 8 marks and 4 marks will be usually. So the question number will be depending upon the question time and other things, it will differ. But together, if I ask all questions, it will be little bit difficult to discuss for the teaching purpose. So I am asking one by one, and some modifications can come during in the examination time. So I think first question I will ask to, first question means first set of questions, case 1 to Dr. Abhishek. Abhishek, are you here? Are you there?
Yes, sir.
Okay.
Ah.
So Abhishek, this is your question. This is a clinical scenario, simple case clinical scenario, very simple, but sub questions will be there. And sub question I will ask one by one rather than asking together, because that I think would more easy to discuss. So a consanguineous couple came to genetic clinic in view of a, I think I'm not saying a 3 months or 6 month old infant with hypotonia and delayed motor development. So it's a hypotonic infant. Just first you have to tell what are the 4 important differential diagnoses we will consider in this situation. Mention 4 important clinical examination findings that will help to differentiate these 4 things. You can take 1 or 2 minutes to just think. Other people can chat box, they can write for differential diagnosis, something like that. So it's very common problem, hypertonic infant, 4 differential diagnosis, and what are the important clinical findings which will help you to differentiate. Otherwise, you can say what 4 important thing you will check or advise or investigation, some important thing in the OPD basis.
Okay, sir.
Okay. Abhishek,
Yes, sir.
can he answer?
Yes, sir. One DD I suspect is the congenital hypothyroidism because there is hypotonia and delayed motor development.
Very good one.
Child might
Okay.
having coast facies. The other one can be an SMA, where there will be examination. There will be peripheral hypotonia. The other one can be like Down
So
syndrome.
hypotonia is for patient is there. Any other finding it will help you to tell.
Maybe the tongue fasciculations can be there.
And
2
things which will help you to tell that it is probably an SMA. One is the tongue fasciculation. Second thing is
that facial. The social smile will be normal.
so that means normal cognitive function.
function.
But in this age group, cognitive function is difficult to assess. But child will be very bright, responding to mother.
Correct.
Social smile will be there. That is the thing, very important. Okay. Then
Down syndrome can also be considered, where there will be facial dysmorphism, other features of then inborn error of metabolism.
Why inborn errors of metabolism? Hypotonia with delayed motor development. Only delayed motor development with hypotonia. Which inborn errors of metabolism will come? And Down syndrome also, usually there will be some cognitive function will be affected. So that is also not a very perfect answer, because we have told hypotonia, delayed motor development. So what does it mean? It means it is mainly motor unit is involved. What are the conditions which other motor units are involved?
Muscular dystrophy.
Muscular dystrophy. What type of muscular dystrophy you will suspect in this age group? So muscular dystrophy is a lot of basket diagnosis. Congenital muscular
myopathy.
Congenital myopathy or a muscular dystrophy? Both can be there. Both can be considered. But what do you want to tell? That's the thing.
Congenital muscular dystrophy.
Congenital muscular dystrophy. Okay, then. So what are the things we will check for congenital muscular dystrophy? Any other PG has written any other diagnosis? Priya?
Sir, Dr. Amman has written SMA along with that congenital myasthenic syndrome.
Okay.
Then congenital myopathy, congenital muscular dystrophy.
Very good.
Again Down syndrome. Then Pompe's Dr.
That is the
Shubhangi.
thing. Another important thing is Pompe disease. Pompe's disease, anybody has written, that is good, because that is you have to consider. Hypotonia, delayed motor development. So what are the other symptoms you will suspect in Pompe? Other features, other features which will give you suggestion that it is Pompe.
Cardiomegaly can be.
Cardiomegaly, hepatomegaly, large tongue. Okay, large tongue. Okay. Any other?
So Dr. Jose has written Zellweger syndrome.
Zellweger. But Zellweger will have usually cognitive dysfunction will be there. Zellweger and Down will have specifically written dilated motor development only. Means less likely, not a better answer. Any better answer always in a hypotonia, motor delay, feeding difficulty, because we have seen these type of patients we will do testing and finally they will end up in obesity. Prader-Willi. Okay. These are some of the conditions. So spinal muscular atrophy, peripheral hypotonia, metabolic myopathies, congenital muscular dystrophy, Prader-Willi, myotonic dystrophy, hypothyroidism, of course, that is I missed it. That is very important. Down syndrome and Zellweger, I think it is. Okay, then we will go to the genetic question, which 5 questions are there.
One question in the chat box: at 3 months, will we be able to assess the cognition?
Now that's it all. Cognition, we will, rather than cognition, patient will be anxious look, pleasant, responding to mother. Otherwise, cognition we cannot do. Developmental delay we cannot say. But patient will be, all SMA patient will be very much active. All this muscular, but there are some mixed findings are there, because in some congenital muscular dystrophy, there can be some CNS manifestations with some leukodystrophy-like pictures or some CNS. But generally, this type of, if you ask hypotonia with a significant motor development, always lower motor neuron diagnosis has to be higher in the list. Okay,
So
then just I have asked.
So he mentioned about the consanguineous marriage. We have to give some importance to consanguineous marriage here.
Correct. That is another important thing.
Down syndrome we can rule out.
Correct. That is the another consanguineous marriage shows that it is an autosomal recessive disorder. So you have to consider SMA, congenital muscular. So this is I've just put at the beginning. That's all. So Abhishek, which genetic test you will advise for confirmation of diagnosis? Which sample to collect? How much anticoagulant use? Special precaution, turnaround time, commonest mutation, role of SMN2 are mentioned. So I will come to that one by one. On examination, tongue fasciculation is present. Which genetic test you will advise for confirmation of diagnosis?
MLPA can be done.
What is MLPA and why it is MLPA you are doing?
MLPA is multiplex ligated probe amplification assay.
Ligation dependent probe amplification. Okay, why MLPA you are using? What is the commonest genetic abnormality? I think that is the next question, but you can tell.
There is a deletion in the SMN gene.
Which SMN gene?
Which at exon 7 or exon 8.
Okay, exonic deletions of the
exon
7 and exon 8 in SMN1 gene. Yes. When you are asked to answer, you should write that homozygous deletion of exon 7 plus or minus exon 8 is confirmatory for the diagnosis of spinal muscular atrophy. Okay.
Yes.
Then he has told that answer. Which sample to collect or anticoagulant to be used?
EDTA use 2 ml EDTA.
2 ml blood in a EDTA anticoagulant. Okay. Yes. So for everybody, it's a DNA test. So sample to be collected is blood. Anticoagulant used is EDTA. Any special precautions during transport?
Precaution.
Nothing is required. If you want a long storage, you have to put into the -20. And later also you can do. DNA test you can do after 1 week, 10 days, any days you can do. What is the turnaround time usually for turnaround time? How many days it will take for the result? Usually
it's 6 weeks.
6 weeks is our routine test, but turnaround time it's not. You can do it in 2 weeks, even within 48 to 72 hours, you can get the result. But most of the lab will take 2 to 3 weeks 2 weeks. Okay.
Yes.
So this is the multiplex ligation dependent. So for all PGs, in all cases where exonic deletions are there, you have to do the MLPA. Any other condition where usually we will see do MLPA?
Duchenne muscular
Duchenne
dystrophy.
muscular dystrophy, where 60 to 70% is due to deletion duplication, we will do MLPA. These are the two situations where MLPA will be used routinely. Then congenital adrenal hyperplasia, where 20 to 30% is due to deletion duplication, you have to do MLPA. These are the three conditions where MLPA commonly used. Then any other condition, neurofibromatosis or any condition where sequencing is, we are not getting result, you can do the MLPA. Then commonest mutation for the confirmation of diagnosed spinal muscular atrophy, already you told. I told you, it's homozygous deletion of exon 7 and or exon 8 in SMN1G. Okay. What is the role of SMN2 in the diagnosis?
It helps in classifying the type of SMA.
So actually it will modify the phenotype. SMN2 will modify the phenotype. Okay. So tell me what much more defined how SMN2 will modify the phenotype.
Copy number should less than or equal to 2. If it's less than 2, it's type 1.
Okay.
Less than 1, it's
Less than 1.
1, it's type
less than 2 means
more,
less than 1 only.
more than 2, it's type 3 or 4.
No, I didn't understood. SMA type 1, how many SMN2?
Type 1, it is 1 or 2 copies.
0 means?
Type 0 is 1 copy.
Yeah.
Copy number is 1 in type 0, 1 or 2 in type 1, 3 in type 2, it is 3 copies. Type 3, it is 3 to 4.
Type 3, 3 to 4. Type 2 is also 3.
Type 2 is 3.
Okay. So it's actually what you have told is correct, but the numbers you have got some confusion. Basically, there are various types of classification. Simplest classification is type 1, type 2, type 3. In that situation, you can say type 1 is 2 or below that. Type 2 is 3. And type 4 and above is type SMA type 3. Type 2 is 3 copies. But some newer classification again will give you the 3A, 3B, type 4, etc. Then you have to again much more refined, you have to do it that the 4 copies will give the type 3A and the 5 copies type 3B or type 4, etc. So that I think it is okay. And why we are getting fasciculation only in the tongue, Abhishek?
Because there is low subcutaneous fat.
So you will get fasciculation in other places? Other places?
Yeah, fasciculation is actually present, is actually present in other areas, but due to this underlying subcutaneous fat, it is not visible.
So any other typical feature we will get in type 3 with the fasciculations?
Type 3, polymini myoclonus.
Very good. Polymini myoclonus, which is seen in outstretched hand, which we'll see in the type 3 SMA. Okay. Sorry. So mention the intrathecally administered antisense oligonucleotide therapy in this condition.
Nusinersen can.
Nusinersen. What is nusinersen? What is ASO? Antisense oligonucleotide.
Antisense oligonucleotide.
What is that? What do you mean by ASO? Antisense oligonucleotide.
It can splice the SMN2 gene, and it can, which in turn itself can produce the SMN protein. after
No,
splicing.
it's not like that.
Um,
But anyway, it will increase it. Simply, you will have to give the right answer as increase the SMN 2 copies. It increases the SMN 2 copies. That will be easy answer, better answer. Because more pathogenesis, everything will be a little bit difficult. So there are 3 types of therapy. Nusinersen, anything can be asked. I have just pushed as intrathecal, that's all. Can be asked oral modifier can be asked, then it is risdiplam. What are side effects of risdiplam? When it will be approved? What is solution asthma? What type of viral vector it is? Anything can be asked because these 3 drugs are now it is in the very hype in the market. Definitely, if SMA has been asked as a thing, something like that, this any type of question can be asked. I just put one question to know that. I think that is about the first question. Anybody wants to ask anything? Anybody has got any doubt? Priya, any other thing they have asked in the...
Sir, number of copies of SMA2 gene besides the phenotype. That is the.
that I have seen. That okay, that is
That's
acceptable.
That's all.
Phenotype. That I have seen. Okay. No other specific comments or other thing. Mohandas, anything you want to add? Mohandas?
No. I think you can proceed to the next question.
Okay. So genetic counseling regarding the natural history of the disease, treatment options, management of complication, multidisciplinary care, prenatal diagnosis, time they can be asked, CVS at 11 to 12 weeks, DNA testing of the fetal sample. Then now carrier screening is coming in way because it is one of the condition where carrier is very common. Carrier status of SMA. What is the carrier status of SMA, Abhishek? In India, what is the carrier status of SMA? One in?
autos.
One in?
150s.
ആരൊക്കെ ഉണ്ട് കൂടെ നമ്മൾ എഫ് പറയുന്ന പോലെ അമ്മ പറഞ്ഞു തന്നാണല്ലേ ഇത് പറയുന്ന പോലെ ആരോ ഒക്കെ ഇവിടെ മർമർ ചെയ്യുന്നുണ്ട്. ഓക്കെ, ഇറ്റ്സ് 1 in 50. It is 1 in 50. It is 1 in 50. And some of the studies from North India and SGPGI in large studies shows it is somewhere around 1 in 40, 1 in 42, something like that. So definitely it is a significant carrier status is there. So carrier screening is also advised. So just cover some of the questions. All this can be asked. What is the recurrence risk? Those things I have not added questions. So much time we don't want to. So next question we will go to Parvati. Parvati is there? Parvati, you can take this question. Couple came for genetic counseling in view of their child is having short stature with a, sorry for the spelling mistake, disproportionate limb shortening. They came for genetic counseling. They are worried about the recurrence risk in the next pregnancy. So first child is having some short stature, disproportionate limb shortening. So one clinical question just for a starting always, rather than go directly to genetic. Mention 2 causes for limb shortening, upper sum and lower sum ratio more than expected, and 2 causes for trunk shortening.
2 causes for limb shortening include achondroplasia.
Okay.
Limb shortening, congenital
Everybody has
hypothyroidism.
written, no. Limb shortening. Everybody has told achondroplasia. Any other? That is why I asked 2. Because achondroplasia, everybody will know. Other causes for limb shortening. Any other skeletal dysplasias you know?
Pseudochondroplasia.
Pseudochondroplasia. We have seen 2 days back only, Parvati, in the OPD. You told limb shortening is there. Okay. So pseudochondroplasia. Then hypochondroplasia. Hypochondroplasia. These 3 at least you can remember. Achondroplasia, hypochondroplasia, pseudochondroplasia. Okay. Then 2 causes for trunk shortening.
Trunk shortening includes spondyloepiphyseal dysplasia.
Okay, various forms of spondyloepiphyseal dysplasias.
Then in case of mucopolysaccharidosis.
Okay, that also one form of spondyloepiphyseal dysplasia only. But okay, Morquio syndrome or those type of patient trunk shortening will be there. Any other? So basically, trunk shortening will have three types. One is skeletal dysplasias, like spondyloepiphyseal dysplasia, mucopolysaccharidosis, etc. Or it can be a vertebral anomalies. When there is multiple vertebral anomalies like hemivertebra and those type of things, clipple field anomaly when there is a fusion, all these things, there will be a trunk shortening will be there. Third thing is significant scoliosis also, there will be trunk shortening will be there. Okay. So two causes. It is not moving. So limb shortening, achondroplasia, hypochondroplasia, pseudochondroplasia, trunk shortening. Any other answers which has to be discussed? No. We will go ahead.
Sir, osteogenesis imperfecta has been written
Okay.
for limb shortening and Marfan's for trunk shortening.
Osteogenesis imperfecta can produce both shortening. We will not consider as a question Kisilum Oskilum best response answer. So it may or may not be. That depends upon where is the fracture, where is the problem. If there is a predominantly limb fracture and there is a bowing of the limbs, there will be limb shortening. But similarly, there is a trunk problem, so trunk shortening also. Okay. So it is not a classical finding where there is limb shortening and trunk shortening we can expect. Similarly, hypothyroidism. Hypothyroidism, basically it can produce both because there is epiphyseal dysgenesis is there. So it may be proportionate or disproportionate. If disproportionate also, how much which is involved. So we cannot say it's a strictly speaking trunk shortening or limb shortening. It's a classical examples are achondro, hypochondro or pseudochondroplasia, spondyloepimetaphyseal dysplasia or vertebral anomalies. Osteogenesis imperfecta depends upon which area is more involved. We have seen both. Depends upon limb or trunk is more involved.
Cranioectodermal dysplasias.
Cranioectodermal dysplasia. That is actually skeletal dysplasia. What cranioectodermal dysplasia? Basically, limbs will be short. That's true. Limbs will be short. That is Ellis Van Creveld syndrome. Their limbs will be short. Agreed. But these are the very common and simple conditions. Cranioectodermal dysplasia is correct. There are so many skeletal dysplasias where limb shortening is there. But I have told a very common situation where you can remember the conditions. Then where for clinical characteristic manifestation of achondroplasia, Parvati, fast.
Sir, rhizomelic shortening.
Very good. So rhizomelic shortening will, in the infancy, what are the classical features in rhizomelic shortening?
There will be increased arm folds.
Correct. Multiple skin folds will be there.
Multiple skin folds will be there. The hand will be short and stout with fingers resembling trident sign.
Trident hand. Okay. So you cannot approximate the fingers. Trident hand. That is second important finding. You will get it. Then third.
Clinical features include there will be macrocephaly.
Macrocephaly.
Facial hypoplasia.
Correct. Mid-face hypoplasia, macrocephaly. Then.
And there will be hyperextensible joints.
Hyperextensible joints. Okay. And when child starts walking, what about the spine? There will be exaggerated lordosis. Okay, exaggerated lordosis or abnormal gait, but that is in an older child only, not in the very young child. They cannot walk. So trident hand, apparent large head, macrocephaly. These are some of the classical features by which you can diagnose an achondroplasia. Any other answers? Okay, so what's the first test you will do for this patient in the OPD suspected case of achondroplasia?
We can, since it is a single gene mutation, we can go for restricted fragment length polymorphism.
I told you will tell the answer. That's the problem. In the OPD directly, you will go to genetic testing.
No.
Clinical direct always you should go by diagnosis one by one.
Sir.
So here, what is the first test you will do? The first thing you will do for this patient when you suspect
skeletal survey.
Skeletal survey. Answer should be skeletal survey. Answer should be skeletal survey. So what are the skeletal survey you will do? What are the X-rays you will take for skeletal survey?
Skull X-ray.
Skull X-ray. AP and lateral or both or one.
AP and lateral.
AP and lateral. Okay, then
Then spine X-ray, thoracolumbar and lumbosacral spine should be taken. Limb
be
X-rays
taken.
should all.
you just when will you write should be taken away thoracolumbar spine, AP and
Lateral.
both are important.
What
Because
are
in
what?
two things we will identify two different findings. Then third,
Limb X-rays, extremity limb X-rays. We have to look for extremity changes. We have to look for take limb
Then-
X-rays.
then
Hip X-ray. X-ray pelvis should be taken.
okay. Then okay, so a characteristic skeletal survey includes thoracolumbar spine AP lateral, X-ray of the pelvis with the hip AP view, X-ray of the both hands with wrist AP view, X-ray chest PA view, one limb, upper limb or lower limb, depending upon which is more involved, one entire limb, and X-ray of the skull AP and lateral. This should be the answer. X-ray skull, you have to add it. But practically, usually what I will do, I will not take that is finally I will just add. I will not take X-ray skull AP lateral for all patients because what I felt utility in that case is very, very minimal and we can reduce the X-ray exposure to the skull. That will be better. So rest of the X-ray I will take. But if you take the textbook description, skeletal survey, all these things has to be taken. Okay. So tell me 3 or 4 cardinal findings in X-ray.
X-ray pelvis, there will be small rounded iliac bones.
What's that
Horizontal
called?
acceptable.
Squaring of the pelvis.
Squaring of pelvis.
Squaring of the pelvis. Then,
The pelvis. Then horizontal acetabula. Then
very good.
coming to the X-ray spine, there will be the distance between the pedicles will be decreased.
That is in the AP view.
AP view.
That is in the PA view or AP view. And what about lateral view?
There will be beaking of the.
Beaking, no beaking in
No.
achondroplasia. Beaking is in spondyloepiphyseal dysplasia, mucopolysaccharidosis, etc. Here, what it is? It's a bullet-shaped vertebra.
Short pedicle.
Bullet-shaped vertebra. It will look like bullet type after some time. Okay.
Okay,
Then, no beaking. Here, no beaking. Then, hand X-ray. Okay. So, what's the genetic defect in achondroplasia and which test will be used for confirmation of diagnosis?
Achondroplasia genetic defect is FGFR23 mutation.
FGFR23.
FGFR3 mutation.
FGFR
FGFR3, sir.
FGFR3 or 23 or?
3.
3. Okay. FGFR23 illa, FGF23 avullu. Ade the condition FGF23.
Vitamin D resistant rickets.
Okay, hypophosphatemia rickets. Okay. So FGFR3 gene. Okay. What is the common mutation? You don't have to know. Okay. Then which test it will be used?
RFLP.
Why you are using RFLP in this patient?
Because the single gene mutation which we are suspecting a specific gene mutation.
The answer should be every patient will have, or most of the 99% will have same mutation. So we can use a mutation specific test like RFLP. This is the only one condition where we can say practically all, 99.9% will have a same mutation, same missense mutation. Okay, 1138G28C. So in that situation, you can do the RFLP, restriction, fragment, length, polymorphism. Okay, point mutation in FGFR, 1138G28, sequencing of the gene or mutation specific testing, RFLP, both can be done. Okay, so this can be asked. This is the chromatogram of the gene sequencing. So each color will show the different nucleotides. Here you can say everywhere there is only one spike. Here you can see that the two spike is there. One blue is there, one black is there. That is there is C2G mutation is there. This is the achondroplasia mutation site, 1138 gene. So it is an achondroplasia mutation depicted. So this is because it is a sequencing chromatogram. It is a sequencing chromatogram in Sankar sequencing. ഇത് ഇന്റർപ്രറ്റ് ചെയ്യാൻ പറ്റുമെന്ന് എനിക്ക് തോന്നുന്നില്ല. ഇന്റർപ്രറ്റ് ചെയ്യാൻ നിങ്ങൾക്ക് ഓരോന്നിനും ഇപ്പോൾ ഗോഷ ഡിസീസിൽ എങ്ങനെയാണ് അത് ഐ ഡോണ്ട് തിങ്ക് ഇൻ എ സ്മോൾ ഒരു ഫിഗറിൽ പറ്റത്തില്ല. ബട്ട് വാട്ട് ഡസ് ഇറ്റ് ഡിനോട്ട്സ്, വാട്ട് ടൈപ്പ് ഓഫ് ജെനറ്റിക് ടെസ്റ്റ് ഇറ്റ് ഈസ് ക്യാൻ ബി ആസ്ക്ഡ്. സോ ഇറ്റ് ഇസ് എ സീക്വൻസിങ് ക്രോമറ്റോഗ്രാം ഇൻ എ സാങ്കർ സീക്വൻസിങ്. സാങ്കറിലെ വരുള്ളൂ, എക്സോമിൽ ഇങ്ങനെയല്ല കിട്ടുന്നത്. എക്സോം ഈസ് ടോട്ടലി ഡിഫറെന്റ് ഔട്ട്പുട്ട് വിച്ച് ഐ ഡോണ്ട് തിങ്ക് വി ക്യാൻ ഷോ ഇൻ എ സിംഗിൾ. ദിസ് ക്യാൻ ബി ആസ്ക്ഡ് ബിക്കോസ് ഇറ്റ്സ് എ സ്റ്റാൻഡേർഡ് ജേണലിലൊക്കെ കാണും, ക്രോമറ്റോഗ്രാം കാണും. സോ ഈ ക്രോമറ്റോഗ്രാം യു ഷുഡ് നോ, സംടൈംസ് ക്യാൻ ബി ആസ്ക്ഡ് പുതിയ പുതിയ ക്വസ്റ്റ്യൻ ചോദിക്കുന്നതിന്റെ ഭാഗമായിട്ട്. ആൻഡ് മോഡ് ഓഫ് ഇൻഹെറിറ്റൻസ് ഓഫ് ദിസ് കണ്ടീഷൻ, വാട്ട് ഇസ് ദ recurrence risk in next offspring of this couple? They are worried.
Mode of inheritance is autosomal dominant. Recurrence risk in next offspring, 50% chance of transmission to the offspring.
Okay. So what do you mean? അതായത് ഇപ്പൊ അച്ഛനും അമ്മയും വന്ന് ചോദിക്കുകയാണ് എന്റെ കുട്ടിക്ക്, അപ്പൊ അടുത്ത കുട്ടിക്ക് വരാൻ 50% ഉണ്ടെന്നാണോ? വരാൻ സാധ്യതയുണ്ട് അല്ലേ?
വരാൻ സാധ്യതയുണ്ട്.
This is the most important thing because we are all learned that autosomal dominant condition is 50%. But this is for the offspring of the child. If next offspring of this couple means we have to see that one of the parent is affected or not. If one of the parent is affected, recurrence risk in the next offspring is 50%. If both parents are normal, recurrence risk in next pregnancy is negligibly low. It's almost 0%. Or 1 in 400 is the empirical risk. I think everybody understood? So,
yes, sir.
When the recurrence risk you are telling, you have to tell that whether parents are affected or not. If one of the parent affected, then recurrence risk in that couple is 50%. If both parents are normal, this disease in this child is due to new sporadic mutation, which is very, very common in achondroplasia. 80% of the cases are due to new mutation, where recurrence risk is negligibly low. Empirical recurrence risk is 1 in 400. It's very important. Autosomal dominant, you have to see whether it is a sporadic or one of the parent is affected. When parent is affected, recurrence risk is 50%. When negligibly low, if both parents are not affected. This is a condition where 100% penetrance. So that Mohandas will tell about later about the penetrance. So always this type of conditions, we have to give the anticipatory guidance. So what is the usual height of every joining? Height or one adult height. What's the usual height of an achondroplasia child as an adult? They are worried. Parvati?
Sir.
Achondroplasia is a normal height, a rough height, adult ആകുമ്പോൾ. Anybody? Priya, anybody has answered?
No, sir.
Okay. So that is why this is important because in
180 to 130 female.
118
to 130.
Okay, correct. Around 118 to 126, 124. Females 2 centimeters low. So it's around 124, 126, that range. So this anticipatory guidance, not in achondroplasia, just it's a classical condition where pediatrician can teach. That is why I have taken this. In any patient, any genetic condition, even rare condition, now we are having literature to say that what's the natural history of the condition. So genetic condition contributing in a way to advantage, we will be able to counsel them. What are the problems child can develop in each stage? Either classical example ആണ് height of an achondroplasia child, which is very, very common. നമ്മളിപ്പോൾ newborn കണ്ടുപിടിക്കുമ്പോൾ എല്ലാ പാരന്റ്സും ചോദിക്കും അഡൽട്ടിൽ എത്രയായിരിക്കും. So you can say around 124. And that is also important when you are discussing about various treatment for increase in height. So that I am not going to that detail. And final 120 to 130. Last question, mention the new medicine available for achondroplasia to increase in height. New medicine available. എന്താണ് new medicine? Parvati?
Sir.
എന്താണ് new medicine? Okay.
I
Any
don't know,
other
sir.
person has written, Priya?
Voratide.
Vosaritide. It is not voratide, it is a vosaritide. Very good. Who has written? Very good. Anyway, congrats.
Aman. Dr. Aman.
Aman. Vosaritide. Vosaritide is a new gene therapy type of molecule which has to be given subcutaneously weekly for the increase in height, which is not available in India. It is not a 100% cure medicine, but there is some improvement is there. So just I have kept different types of questions to share that. First question will be some basic clinical questions, like what are the differential diagnoses, important clinical features. Then there is a genetic testing. Then there will be anticipatory guidance. So usually, I think definitely any of the examiner will put question like that, any condition. So you can expect this type of question. These are all examples. This is achondroplasia. You can see the classical X-rays, FGFR mutation, phenotypically normal parents, recurrent one. Any other question? Anybody wants to ask anything? Or I will go to
one doubt. Joint laxity, Parvati said, is it a common joint laxity?
no, sir. Joint laxity illa. Atlantoaxial problems ullavarku. Joint laxity, ella joint വലിയ laxity is not common. That's I have not written in that 5 features. Atlantoaxial നമ്മൾ rare ആയിട്ട് കാണാറുണ്ട് because they are having very small what you can say osodundum. So in very few people there can be a quadriplegia നമ്മുടെ രണ്ട് പേഷ്യൻസിനുണ്ട്. So that they can develop.
Pseudoachondroplasia, can it be differentiated to some extent from the skeletal survey?
Definitely. First of all, pseudoachondroplasia and hypochondroplasia will not present in the early ages. When the child present at the age of less than 6 months with significant shortening, 99% it is achondroplasia only. This hypochondroplasia usually will come in the കുറച്ചുകൂടെ older age group. നമ്മുടെ ഗ്രോത്ത് ഹോർമോൺ ഒക്കെ വരുന്നത് പോലെ കുട്ടി വളരുന്നില്ല എന്ന് പറയുമ്പോഴാണ് നമ്മൾ ഡയഗ്നോസ് ചെയ്യുന്നത്. And even in our growth hormone series, Tamil Nadu, hypochondroplasia, they are giving growth hormone because they felt that it looks like growth hormone and growth hormone will be deficient. It is very difficult to differentiate. Whenever child is having a mild short stature, 2 important conditions you should rule out is hypochondroplasia, spondyloepiphyseal dysplasia, and multiple epiphyseal dysplasia. ഇതിൽ മൂന്നിലും ഒരു mild shortening ആയിരിക്കും. So achondroplasia ആയിട്ടുള്ള ഒരു DD വരുന്നില്ല അവിടെ. Pseudoachondroplasia is still interesting thing. They will present at the age of 2 to 3 years. But interesting thing is their limbs are short, but significant spinal abnormality will be there on the X-ray. Spinal middle morchio middle beaking. There are so many epiphyseal involvement will be there. So their picture is totally different. An interesting thing is adult with pseudoachondroplasia, the spinal abnormality will not be there. You have to pick it up only in the growing period. So pseudoachondroplasia is very difficult to suspect. You will most of the time we will suspect as some spondyloepiphyseal dysplasia or some other skeletal dysplasia. And finally, you will get in mutation, COMP gene mutation, that is pseudoachondroplasia. It is one condition clinically.
Face will be normal also.
Face will be absolutely normal. Perfect. Face will be absolutely normal. It looks like a normal child. Only thing is limb shortening. X-ray spinal abnormality. പക്ഷെ നമ്മള് spondyloepiphyseal dysplasia trunk shortening ആണ് വരുന്നത്.
Head shape in the കാര്യം
ഇല്ല സാറ് മ്യൂട്ട് ആയി പോയി. ഇല്ല പുരുഷോത്തമൻ സാറ് മ്യൂട്ടാ.
head shape will be larger with midfacial hypoplasia in both achondroplasia and hypochondroplasia.
Yes, but hypochondroplasia mild degree ആണ്. Mild degree ആണ്. പിന്നെ എക്സ്റേയില് ഹൈപ്പോകോൺട്രോപ്ലേസിയയില് ട്രൈഡന്റ് ഹാൻഡ് കാണത്തില്ല hypochondroplasia. That is one important thing. Never you will get it. Then early presentation വരത്തില്ല. Then mid-face hypoplasia and macrocephaly അത്ര abnormality കാണത്തില്ല. Then most important differentiating finding is the X-ray of the thoracolumbar spine, AP view, where in achondroplasia, interpedunclar distance കുറഞ്ഞു വരുന്നത് ഇവിടെ straightened down. So it's a very mild feature. But ബാക്കിയുള്ള സ്ക്വയറിംഗ് അതൊന്നും കാണത്തില്ല. ഇതിൽ you can see a typical squaring and reverse 3 sign, etc., which will not be there. Okay. Okay, so last question. സമയമുണ്ടോ? മോഹൻദാസ് ഒരു question കൂടെ സമയമുണ്ടോ?
നമുക്ക് കുഴപ്പമില്ല തോന്നുന്നു. എനിക്ക് തോന്നുന്നത് PG സെല്ലേ ഉള്ളൂ, പഠിക്കുന്ന സെഷൻ അല്ലേ. അപ്പൊ വി നീഡ് നോട്ട് റെസ്ട്രിക്ട് ടുഡേ. ദർ ഇസ് നോ പ്രോഗ്രാം ഓൾസോ. ഐ തിങ്ക് സെയിം പേസിൽ പോയിട്ട് വി ക്യാൻ ഫിനിഷ് ബൈ 9:30 ദാസേ. 9 o'clock നോക്കണ്ട. ഇന്ന് PG
ഒരു ക്വസ്റ്റ്യൻ കൂടെ ഉള്ളൂ. മൂന്ന് ക്വസ്റ്റ്യൻസേ ഉള്ളൂ.
പറഞ്ഞേ നമ്മൾ ആന്റിസിപ്പേറ്റഡ് ടൈമിനകത്ത് കുറച്ചുകൂടി സ്ലോവർ ആണ്. ദാസിന്റെയും ഗിരീഷിന്റെയും കൂടി കഴിയാനാം ടൈം എടുക്കും. 9:30 ആവും.
അതാണ് ഞാൻ പറഞ്ഞത്. എനിക്ക് തോന്നുന്നു ഞാൻ കുറച്ച് സമയം എടുത്തു.
നൈസ്.
ഓക്കെ, ഇത് ലാസ്റ്റ് ക്വസ്റ്റ്യനാ. ഈ ക്വസ്റ്റ്യൻ കൂടുതൽ ചോദിക്കാനില്ല, ഡിസ്കസ് ചെയ്യാനേ ഉള്ളൂ. So it is can be asked about the match the following. Identify the most appropriate test for the given condition. Merin undo Merin?
Yes, sir.
Okay. So all of you can see this. I have put the condition on the left side. Various conditions you will see in pediatric practice. Right side, all upper test is there. So you can take 2 minutes to look into that. Then one by one we will tell. You take sickle cell anemia. What is the test from the right side? Then why you have selected. Thalassemia, right side test. Why you have selected. Just tell fast. We will finish it within 5 minutes or 10 minutes maximum. Okay. So Merin, are you ready?
Sir, sickle cell anemia.
Sickle cell anemia. RFLP. That I think RFLP. No, slow you go, because any wrong is there, I have to discuss. We don't have to unmute every time. We unmute. Merin. So sickle cell anemia, RFLP, because already we told same principle. It's 100% cases. It will be same mutation. So in this type of mutation specific testing, you will use the RFLP, mutation specific testing. Sequencing can be done, but RFLP is enough. That is why I put the most appropriate. Sequencing can also be done. Okay, thalassemia.
Thalassemia, Sankar sequencing.
Very good, very good. Sankar sequencing. Why you are noticing you are in Sankar sequencing, not exome?
Different types of mutations can be seen in a different single gene.
In a single gene, that's the thing. It's the same gene. It's only
Same
3
gene,
exons, same
different
gene,
types of,
different
say,
mutations.
different types
So
of mutations.
Correct. So previously we used to do mutation specific testing, but now better test will be Sankar sequencing, where the more than 200 to 250 mutations are there. So all mutations can be picked up. So conditions like thalassemia, cystic fibrosis, etc. Sankar sequencing is the very good. It's a monogenic disorder. Phenotype 1, same gene, different mutations. Okay. Third, Duchenne muscular dystrophy.
MLPA.
Already we told. Most appropriate first test is MLPA, because 70% is deletion and duplications. Very good. Okay. For multiple malformation with the global developmental delay.
Microarray.
Microarray. Very good. Microarray. So microarray, because karyotype will have a low resolution. Karyotype can be done. But microarray is the first test where there is a significant utility is there. So that is a recommendation. First recommendation for first test to be recommended in multiple malformation with the global developmental delay. Unless otherwise, it's a definite monogenic disorder. Williams syndrome?
Fish.
Fish. Why fish? Why fish?
Microdeletion.
Microdeletion
In the Williams syndrome can be detected in
fish. So for a better answer, that word should be there is a targeted testing. Just like this mutation specific testing. Because in fish, you can do only targeted testing. You should know where is the deletion. So in Williams syndrome, DiGeorge syndrome, Prader-Willi syndrome, Smith-Magenis syndrome, where we know that where the deletion has to be checked, fish is the test. Okay. So very good. Williams syndrome, Prader-Willi, DiGeorge, everywhere. Prader-Willi, you can do both. But so Prader-Willi people will not give you to avoid confusion. DiGeorge or William will be a better question can be asked for the fish testing. Then myotonic dystrophy.
Triple primed PCR.
Correct. Because myotonic dystrophy is a totally different mechanism. It's a triple repeat disorder which cannot be detected by any other testing, only by triple primed PCR or TP-PCR. Other conditions with the TP-PCR testing we will use is Fragile X syndrome.
Fragile X, Huntington's chorea.
Correct. Friedreich's ataxia, spinocerebellar ataxia. But these are all specific testing. Okay. Not like exome, karyotype or microarray. One triple prime PCR not for every case. For each and every gene, you have to do separate condition, separate triple primed PCR. Okay. The Russell-Silver syndrome.
Exome sequencing.
Russell-Silver syndrome, commonest type of, so far everything you have done correct. Russell-Silver syndrome. Because Russell-Silver syndrome, commonest cause is methylation abnormality. Methylation abnormality. So methylation sensitive PCR.
PCR.
Methylation sensitive PCR, which will be Russell-Silver, Prader-Willi, Beckwith-Wiedemann, Angelman, this type of condition, methylation sensitive PCR. Then osteogenesis imperfecta.
Exome sequencing.
Exome sequencing by next generation sequencing, because there is a same phenotype, multiple genes, more than 24 genes with the different mutations. 24 genes, and each gene will have different mutations. So you cannot look for each and every mutation. So there should be a parallel sequencing of multiple genes. So osteogenesis imperfecta, Marfan syndrome is a large gene. Then muscular dystrophies, apart from DMD, other muscular dystrophy, deafness, all these conditions, exome sequencing is mandatory. That is the best specific test. Turner syndrome.
Karyotyping.
So Turner syndrome, can you do microarray?
Yes, sir. Microarray can also be done.
But why you are not doing microarray? Karyotype, you told answer most appropriate. You can detect Turner syndrome in microarray, but
yeah, since there is aneuploidy and structural abnormality, more specific will be karyotype.
Correct. Very good. So you can identify there is loss of X chromosome is there, but structural anomalies cannot be picked up by microarray. So if you are having isochromosome, partial deletion, everything you will get some loss of X chromosome. So for identifying what type of structural abnormality, you have to identify the karyotype. So any structural anomaly of the chromosomes, you cannot do microarray, like balanced translocation carrier, parents of a child with microarray, where you have to do conventional karyotype. Conventional karyotype, because microarray is a higher resolution, better technique, but cannot identify what structural abnormality you are dealing with. Melas, very easy, because only one
mitochondrial gene
answer. Mitochondrial gene sequencing. Okay. So good, Merin. That is the RFLP, thalassemia, Sankar, MLPA, microarray, fish, triple primed PCR. So it's very, very simple. You don't have to bother about it. Ella testing kuda കാണുമ്പോൾ ടെൻഷൻ ആവണ്ട. ഇങ്ങനെ ഒരു ക്വസ്റ്റ്യൻ ചോദിക്കാൻ നല്ല സാധ്യതയാണ് genetic testing select ചെയ്യാനായിട്ട്. So I think ആ ഒരു principle you have to understand. Anything you have to ask in genetic testing? Any PG or faculty? Or we will go to the next session by Mohandas sir.
Sir, one question in the chat box. Can we use RFLP for Williams syndrome?
No. RFLP, we can use only for the point mutation, number one. Because RFLP is a restriction fragment length polymorphism. When there is a change in one nucleotide, the restriction enzyme will not work. So when there is a mutation, it will work, or when there is not a mutation, it will not work. So for each mutation, restriction enzyme will be different. For that, I think you have to read something about in detail about the what is restriction enzyme, what is palindromic sequence, etc. But generally, most important point, it can be used only in the point mutations. Any point mutation you can use. But the other situation, for each point mutation, you have to use different RFLP, which is more expensive than doing sequencing. So that is why it is not appropriate. But Williams syndrome, you cannot do. Williams syndrome, most of the time, it is a deletion. So you cannot. Williams syndrome, you can use MLPA and fish and microarray. All three can be done. You can do fish, you can do MLPA, you can do microarray. Okay. Mohandas, sorry, I have taken a little bit of time.
It's okay. It's not a problem.
Sorry.
Nice discussion, Sankar. We really enjoyed. Can I share my slide now? Okay.
ഞാൻ പറഞ്ഞു മീഡിയ കുടുംബ സ്വത്താണ് എന്ന് മാത്രം നിങ്ങൾ എല്ലാവരും മുമ്പിൽ പറയാം. അത് മാത്രമേ എനിക്കറിയുള്ളൂ, വേറൊന്നും അറിയില്ല. മീഡിയ എനിക്ക് എഴുതി തരാത്തത് ഒരിക്കൽ പറഞ്ഞ ജഗദീഷാണ് സുഖമായിട്ടോ അവരെല്ലാം വന്നു പിന്നെ പറഞ്ഞ അത് ലോൺ എടുത്തിട്ട്
ആരെങ്കിലും ഒന്ന് ബാക്കിയുള്ളവരെ മ്യൂട്ട് ചെയ്യോ? Can you see my screen?
കാണാം.
Okay. So,
Okay, right.
okay. So today we will have some Osce on the pedigree, which is very common to be asked for the exams. And all of us know that drawing a pedigree is really important in when you are analyzing a genetic condition. So the first question is to Dr. Anjali. Anjali, is she here?
Yes.
Okay, so you have to identify the inheritance pattern here, and you have to identify anything which is unusual or atypical in that particular inheritance which is depicted here. And also you have to give one example each where that particular atypical feature is present and also that feature is not usually seen. So
Okay,
what
sir.
is the inheritance pattern?
It is autosomal dominance.
Why do you say it is autosomal dominant?
Since individual and all generations are affected with male and female equally affected, and male and females equally transmit the disease.
Okay. What other
So it is
feature?
most. So here one generation is not affected at all.
One generation is not affected at all. All the 4 generations are affected here.
One of the affected parent is have a
One of
child
the,
with
usually in autosomal dominant inheritance, one affected individual will have one affected parent.
Child. Yes.
Here, in the 3rd generation, that a child do not have an affected parent, isn't it?
Yes.
Okay. So how will you explain that feature in autosomal dominant inheritance?
Sir, it may be due to incomplete penetrance.
Incomplete penetrance. That particular parent that is in this pedigree, the father of that child will be having the genetic abnormality but not manifesting, which is called as
incomplete penetrance.
Incomplete penetrance. Genetic abnormality is there, but there is no phenotypic abnormality. Okay.
Yes.
So can you give example for that such conditions in autosomal dominant pedigree?
With incomplete penetrance, conditions like neurofibromatosis.
Okay, neurofibromatosis or tuberous sclerosis. You can see some individuals may have the genetic abnormality, but they may not be having any of the clinical features. What will you call if there are very highly variable features? Some will be mildly affected, some will be severely affected.
It is called variable expressivity.
Variable expressivity. That is another common feature you see in autosomal dominant inheritance. So can you name one condition where you, even though it is an autosomal dominant condition, you won't see this incomplete penetrance?
Achondroplasia.
Already Dr. Sankar has mentioned there is 100% penetrance in achondroplasia. So there is no scope for incomplete penetrance or variable expressivity and all. Okay, very good. So I think Anjali has answered all. Okay, so Priya, any other answers or any comments which needs explanation?
No, sir.
Okay.
No.
So when you are seeing a pedigree, you should see whether multiple generations are affected or not. When multiple generations are affected, you should see whether which sex is transmitting the disease, whether the male is transmitting, female is transmitting, or both sexes are transmitting. And also you should see whether the condition is transmitted to male only or female only or both sexes, whether all male children are affected or all female children are affected, like that. So by looking into this, you will be able to identify the pattern of inheritance. Okay. So now this question I will ask to Jose is here.
Yes, sir.
Okay, so this is a pedigree chart where this is a family with sickle cell disease. Many members are affected in this pedigree. So how will you explain this phenomenon? What is the inheritance pattern of sickle cell disease?
Autosomal recessive pattern.
So how will you explain all the generations are affected?
It is known as pseudo-dominance due to marriage in close communities, like in Wayanad, tribal populations marrying among themselves, and one of the parent is affected, and the other is carrier. So the generations are equally affected and behave like an autosomal dominant condition.
Okay, in a particular, there are certain communities where they marry only, it is restricted. They marry only a member of their own community. And if the carrier frequency is very high in that community, you can get all generations to be affected, because in this pedigree, this number 2 is going to be a carrier. So that is why the 2 members in the next generation are affected. And in this here, this lady also will be a carrier. Hope you are seeing the cursor. Can you see the cursor?
Yes, yes, sir.
Okay, so since this lady is a carrier, there are 2 offsprings are affected here. So this is called a pseudo-dominant inheritance of an autosomal recessive condition. I'll ask one more question. Another type of close community is Ashkenazi Jews, and the carrier frequency of Tay-Sachs disease is really high there. So can you get pseudo-dominant inheritance there?
Don't know, sir.
Any answers? Anyone would like to answer? Because in sickle cell anemia, an affected person can reproduce, whereas Tay-Sachs disease, they won't reproduce. So an affected person cannot transmit the disease to next generation, but if the marriage is between 2 carriers, they can transmit. So the chance is less in this particular condition, where there is a lethal condition and the affected member will not reproduce. Okay.
Okay.
Can anyone say what is pseudogenetic conditions? Pseudogenetic. Anyone? Suppose more than 1 siblings will be affected, but it is not due to a genetic problem, maybe due to an environmental factor. One example is fetal alcohol syndrome. More than 1 sibling may be affected. They may be dysmorphic with some structural organ problems, but there is no genetic factor implicated there. Is it clear?
Okay, sir.
Any comments or any clarification needed, Priya?
No, sir.
Okay. Then I'll move to the next pedigree. This is the pseudo-dominant we have already discussed. So this I will ask to Nikhil Reddy is here.
Yes, sir.
Okay, so you have to identify the inheritance pattern, and also you have to mention why you have told that inheritance pattern. You have to list 4 conditions which is inherited in this manner, and what is the reason for high degree of variability in severity in this sort of inheritance.
Sir, it is mitochondrial inheritance.
Why do you say so?
All the only females are transmitting the disease to all the offsprings, and males are not affected. Males are not transmitting the disease.
Why affected males do not transmit a mitochondrial gene abnormality?
Because usually sperm contains very relatively very few mitochondria, which will be degraded after fertilization. So the zygote will get the mitochondria from the female itself.
From mother only. The zygote will get the mitochondria from mother only.
Mother only. Yes,
okay. So here, as you have already mentioned, the affected female transmit the disease to all offsprings, affected whether all male and female offsprings, and affected male do not transmit the disease. So that is why the condition is it is mitochondrial disorder. Can you name few conditions inherited in this manner?
Leber hereditary optic neuropathy, MELAS.
What is expansion MELAS?
Mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes.
Okay.
In neuropathy, ataxia retinitis pigmentosa, NARP.
Okay. Yes.
Chronic progressive external ophthalmoplegia, CPU.
Okay.
Pearson syndrome.
Pearson syndrome. What is MRF? MERFF. MERRF.
Myoclonic epilepsy with ragged red fibers in muscle.
Okay. So what is the reason for high degree of variability in severity in this sort of inheritance?
It is due to the phenomenon called heteroplasmy, sir.
What is heteroplasmy?
Cells contain normal and abnormal mitochondria. So the expression, there will be normal mitochondria. Normal mitochondria will be there. So there is a variability of
depending upon
clinical
the
manifestations.
Number of
copies of
abnormal gene, the mitochondria with which carry this abnormal gene, the proportion, the normal and abnormal genes, the clinical feature will vary. So that is called heteroplasmy. Even though the mother transmit the disease to all children, all may not receive the same dose of the abnormal gene. So that will result in variability in the phenotype. That is called heteroplasmy. Then one more feature of mitochondrial inheritance is called threshold defect. What is that threshold defect? Any idea? Nikhil? Or anyone else want to answer? Threshold
variable.
Anjali want to answer? Threshold defect.
Variable.
Okay, threshold defect is a particular quantity, a particular dose of abnormal gene is required to manifest the disease. If the dose is below that, the disease will not manifest. So that is called a threshold defect in mitochondrial inheritance. Any other answers, Priya, or anything to be clarified?
No, sir.
Okay. So if this variable clinical feature is in an autosomal dominant condition, you will call it as variable expressivity. In mitochondrial disease, you will call it as threshold heteroplasmy. So this is heteroplasmy. In the left extreme, it is homoplasmy, no abnormal mitochondria, or the mitochondria carrying the abnormal gene. As it goes to the left end, the number of abnormal mitochondria increases, and once it crosses that threshold level, the disease starts manifesting. Now I'll ask to, is Kavya here? Kavya?
Yes, sir.
Okay. So can you say, here you can see 2 pedigree. So can you say what type of inheritance is shown here?
X-linked dominant, sir.
Why do you say so? Both are
Because
X-linked dominant?
first one.
Why do you say so?
Because the affected male will transmit to daughters, but sons will be normal.
What about the affected females transmitting the disease?
It will transmit to both sons and daughters.
All sons
50% sons and 50% daughters.
Okay. So whenever I have initially mentioned that whenever you see multiple generations getting affected, you should see who all are transmitting, whether male and females transmit the disease. Here, male and females transmit the disease. Whether they transmit equally to males and females. Here you can see that the male transmit the disease to all daughters, but not to the sons. Whereas the female transmit the disease to both son and daughters, but not to all. There are unaffected individuals also. So that makes this an X-linked dominant inheritance. So Kavya, what do you think regarding the severity of the condition?
Males will be severely affected, sir.
Why?
Because there is just one X chromosome.
Male have only one X chromosome, which is abnormal here. So male will be severely affected, whereas the female will be somewhat mildly affected in X-linked dominant inheritance. Can you give an example for such a condition?
Rett syndrome. Hypophosphatemic vitamin D resistant rickets.
The classic example is X-linked hypophosphatemic rickets,
okay,
where the male will be severely affected, females will be mildly affected. Okay.
Okay, sir.
Can you, what about the hemophilia? Is it X-linked dominant or recessive?
X-linked recessive.
Strictly speaking, there is nothing called a true X-linked recessive condition. You cannot answer this for exams. So it is a spectrum. Even the hemophilia carrier will be having a slightly reduced percentage of the factor. Okay.
Okay.
Similarly, what about Duchenne muscular dystrophy? Is it X-linked dominant or recessive?
Recessive.
Even though it is mentioned as recessive, the carrier females are not completely free from the disease manifestations. Some of them will have hypertrophy, some of them will have elevated CPK levels, and more than that, in their 40s or 50s, they can suffer from cardiomyopathy. Okay, so in strict sense, it also is an X-linked dominant condition where the females are mildly affected, but for all exams, you can mention that hemophilia and Duchenne muscular dystrophy are X-linked recessive. What pedigree shown here is X-linked dominant. What about this B, the other pedigree?
Don't know, sir.
Okay. So in certain other conditions, the other extreme situation, the male will be so severely affected that they will either die in utero or may die in the newborn period. So that again is the females are mildly affected, so they can live with the disease, whereas the male can either die in utero or die in the newborn period itself. So that is again X-linked dominant condition. Can you give an example for that?
Rett syndrome.
Rett syndrome. So Rett syndrome usually manifests in the female. The male can also manifest so severely that they will die with the encephalopathy like situation in the newborn period itself. Other examples are
Incontinence.
this I have already mentioned, X-linked dominant. So other examples will be IAP syndrome, where those with the corpus callosal agenesis and seizures, incontinentia pigmenti, Gold syndrome, which is focal dermal hypoplasia. So all these conditions are X-linked dominant with the males so severely affected that they won't survive.
Okay, sir.
Okay. Any comments or any other answers?
During 80s, we were learning more about the Lyon's hypothesis when you're talking about the partial expression of this females expressing this thing, short limbs in the case of X-linked hypophosphatemic rickets, and some of the calf and enlargement in a carrier mother. The Lyon's hypothesis was nowadays it is not much discussed. Is it now obsolete? Nobody is talking about Lyon hypothesis now.
So that is still there. So that hypothesis still there, sir. And that may be the reason for the females manifesting with the disease. For example,
CPK elevation will be there.
The usually, since one X chromosome alone, because the double dosing of the genes in X chromosome is not needed, so naturally one X chromosome will be suppressed, and that is usually a balanced, almost 50% of the one X and 50% of the other X will be suppressed. If there is an imbalance and the chromosome which have the normal gene is suppressed more, then the disease can manifest. Okay.
So we will call this skewed X inactivation.
Skewed, yes.
Lyon hypothesis or inactivation is a normal phenomena which occurring in the every individual. It's a normal phenomena. When it is skewed, as Mohandas told, it is skewed towards more of the normal things are suppressed, then the patient will be manifesting. That is why, as I rightly pointed out, some DMD will have a cardiomyopathy, some hemophilia have bleeding manifestations. So depending upon the manifestations, it can be considered as dominant or recessive, but generally we will consider as recessive.
Oh, okay. In this family, there are many affected individuals with the spasticity and unsteady gait. And the age of onset of clinical manifestations are shown here. The first generation, it is around 70, 73 years. In the second generation, it is around 40 or 35 years. And the last generation, it is much early. So what is this inheritance pattern and what phenomenon is depicted in this pedigree? And name 4 conditions showing this feature. Who is answering? Anyone can answer. Who is answering? Jose?
Sir, X-linked Recessive pattern.
X-linked recessive, no. Why X-linked recessive?
Females.
Here you can see that one male also is transmitting. That is shaded differently, but male also is transmitting. But why should there is a different age of manifestation? So the pedigree is something like autosomal dominant, but as in successive generations, the condition is either manifesting early or it can be severe in successive generations. What will you call that? Anyone? Priya, anyone has answered?
Answers in the chat box. Anticipation.
So this is called anticipation. What sort of conditions show this anticipation? I think Dr. Shankar has already mentioned it in his session. What sort of conditions show anticipation? Anyone answered? Priya?
So, digenic inheritance.
Not digenic. It is triplet repeat expansion type of disorders. Which are the conditions grouped under this characteristics? Triplet repeat expansion. Anyone? Anjali? Triplet repeat expansion?
Example.
So it is congenital myotonic dystrophy, Huntington's disease, Friedreich's ataxia. Here, what could be the condition? Unsteady gait and spasticity, spinocerebellar ataxia. All these conditions are triplet repeat expansion type of disorders. And there, in successive generations, the amplification of the triplet repeats increase. And the manifestations will be at an earlier age, or the manifestation can be more severe. Okay. And peculiarity is in congenital myotonic dystrophy, if the mother is transmitting the disease, the severity is more. So if you are seeing a newborn who is floppy and is ventilator dependent and diagnosed as congenital myotonic dystrophy, most often the transmitting parent will be the mother. Whereas in Huntington's disease, if it is from the father, this anticipation occurs. The manifestation is earlier. Okay. So can I stop now? I will stop here. Okay. Any doubts? I think Dr. Gireesh can start the session now.
That was an excellent session on pedigree and pedigree related questions.
Just 1 minute. Sir, I will be leaving. I have some other engagements now. Can I leave?
Okay.
So shall I share the screen? My screen?
Yes. Full screen ആക്കിക്കോ. Full screen.
Okay. So I'll be discussing 4 questions regarding Down syndrome, which is one of the commonest abnormality, chromosomal abnormality that you see in daily practice. So, not moving. Yes. So who is answering the question? Dr. Jose?
Yes, sir.
Yes. Actually, these parents of a 4-year-old Down syndrome child came for genetic counseling as they were planning for the next child. Mother is now 27 years and father is 30 years. The carrier type of the child is shown here. So what is the abnormality? Can you identify the abnormality in this carrier type?
Sir, Down syndrome baby, this karyotype showing long chromosome in 14th.
Okay, very good. So it's basically is a Down syndrome child, previous history of Down syndrome.
Translocation.
Yeah.
Due to translocation.
So it's a Down syndrome. So there is no additional chromosome in 21st. It is not a regular trisomy. It is not a free trisomy. So what you're seeing in the 14th chromosome, there is an additional material, right?
Yes, sir.
So there is a part of the 21st chromosome. Okay. So there is a, what is the diagnosis?
A translocation. 14-20 translocation.
Okay. It's a 14-21 translocation. Okay. So usually, what are the usual translocations that you see?
14.
Commonest being will be 14-21 translocation. Okay, agreed. What are the other translocations? Yeah,
15,
13, 14, or 15. These three chromosomes. These are the D groups chromosomes can get translocation to 13-21, 14-21, or 15-21, or even 20-21, or even 21-21 also. Okay. So the commonest translocation that you see is the 14-21 translocation, and second commonest will be 21-21 translocation. So in this scenario, what is the next investigation to be done?
Parents karyotyping should done.
Okay. Okay. How does it help you?
And for parent translocation, if paternal carrier, there will be risk for up to 5 to 2 to 3% is there. The mother is the carrier, then 10 to 15%.
Yes. So first you have to see the parent's karyotype, right? So you have to see that whether it is a de novo translocation or it is a familial one. Okay. So most of the time it is usually de novo. Almost 95% cases usually it is de novo. And 3 to 4% cases it is usually familial. So what about the risk? Suppose it is a de novo translocation. There is no family history. There is no parents are normal. Then what will be the risk?
If the mother, if the age is less than 35 years, then 1% increase risk.
Around 1%. Okay, less than 35 years, usually it is around 1%. The risk is around 1%. Okay, right. After 35 years,
age-related.
This is usually the age-related risk. Okay, age-related risk that you can. There is a chart from which you can calculate the risk actually. What is the risk at 20 years? What is the risk at 30 years? Like that. There is a age-related risk chart. Okay, so that is there is a usual recurrence rate. Okay. Then how will you calculate the recurrence risk in the next pregnancy? That's already you mentioned. Okay. So suppose it is a familial one. What will be the risk?
Familial risk based on maternal age.
No. Suppose mother is the carrier of translocation. What is the risk?
10 to 15%.
Yes, usually it is around 10 to 15%. Suppose father is the carrier?
2 to 3.
Okay, around 2 to 3 or 2 to 5%. Different books giving different this thing. So you can arbitrarily you can take it as 2 to 5%. Okay. Suppose any other extra thing you should need. You need advice on these parents. Suppose it is familial. Anything else you can do? Suppose this mother or father has got siblings, parents or siblings. What else you can do? They are first degree relatives, right?
Yes.
So they can also be
Antenatal.
karyotyping because they may be also be carriers, right?
Yes, sir.
So that also can be done. So what is the generally, how will you calculate the recurrence risk generally? For example, a regular trisomy. What is the risk?
Less than 35 year as like.
Suppose it is a regular trisomy. There is trisomy 21 or free trisomy. Because 95% of cases you can have, it is regular trisomy 21. Okay. So in that case, what is the risk of recurrence? Suppose there
Less
is a
than 35 years, there is 1%, and in more than 35 years, age-related.
No, it is actually age-related risk only. There is no cutoff 35 years like that. Okay, it's only age-related risk. Okay. Suppose, sorry, there is a, as you mentioned, it is 35 years. It is below 35 years. There is 1%. Above 35 years, it is age-related. Okay, sorry. Then what about the translocation? You already mentioned. 1421 translocation, if it is familiar, what is the risk? It's already we discussed actually. What is the other translocation? What are the risks with other translocations? Like 21 translocation, for example.
Robertsonian translocation.
21 translocation, what is the risk?
100%.
No, again, you have to see that parents, if the parents are carriers, there is 100% risk. Okay.
Yes,
otherwise, there is no risk. Suppose it's a mosaic down, what is the risk?
Age-related risk.
Okay, it's again a maternal age-related risk. So these are the three situations: a free trisomy, translocation trisomy, translocation down, and mosaic trisomy. So the risks are slightly different. Okay.
Okay.
So any doubts? Any questions? So this is the picture, and okay, these are the answers. Okay. Yes. Okay. Second question. So who will be answering? Dr. Anjali? Okay, ready? Dr. Anjali is there?
Yes.
Okay. A 29-year-old primate presented herself in the genetic clinic for counseling at 10 weeks of conception. She is anxious to test and know whether he is having Down syndrome or not. So in this scenario, what will you do? What is the indication to screen for Down syndrome? Is it required for a 29-year-old primate? Is it required? And what is the recommendation regarding screening?
Optional action. It is optional. Usually that's when
I'm not hearing the answer actually.
hello.
Yeah.
Sir, it is not required. It is optional in this case.
I didn't get it. Is it optional? What is the ACLT recommendation? Current recommendation? So actually, the current recommendation is to screen all pregnant women, irrespective of the age. Okay. And they should be given an option to select either screening test or definitive test, whatever their demand. Okay. So that is, so all pregnant ladies should be screened for Down syndrome. So what are the screening strategies that are available?
So since she's at 10 weeks of conception, we can do a first trimester screen using beta-HCG, pregnancy-associated plasma protein, and also we can do a USG to look nuchal translucency, nasal bone initialization.
Okay, good. Any other screening strategies for first trimester?
Self-free DNA in maternal serum
Yes,
can
very
be
good. Okay. Self-free DNA can be done. So second trimester?
second trimester, we can go for
Actually, self-free DNA is coming up in a big way. Alle? So there is even though it's slightly costly, it is highly sensitive and the false positive rate is very low. Alle? So it is the latest thing. So what about the biochemical test?
we can go for a triple test, that is AFP, beta HCG, East trial.
What will happen to this?
So
what will happen to the first trimester PAPA, that is pregnancy associated placental plasma protein A?
Sir, in first trimester, beta HCG will increase and PAPA will decrease.
Yes, very good. Okay, then
In second trimester, biochemical test can
okay. Will you do anything extra in the first trimester?
you will see UST to look for nuclear translucency.
Nuclear translucency as well. Okay. So when will you look NT and this? What is the timing of this test?
10 to 14 weeks.
Okay, usually 11 to 13 weeks. That is the ideal testing time. And nuclear translucency also, they have different cutoffs based on the crown rump length. Okay, CRL. So usually 2.1 to 2.7 is the usual cutoff for first trimester. So that also you can measure. Anything else? Suppose it is positive, what will you do?
We have get a diagnostic test.
Yes.
So
okay.
it is in first trimester chorionic villus sample.
So what is the sensitivity? What is the detection rate of this first trimester test? Combined test with NT? How much? How many? What is the sensitivity?
Sensitivity around 80 to 90%.
Okay, first trimester compared to second trimester, it's got a higher sensitivity, around 90% it can detect. Okay, and what is the false positivity rate? That means if the negative, they can,
around,
yeah.
Specificity is around 90 to 98%.
False positivity? Around 5%. Okay, around 5% can be falsely positive also. So what are the second trimester tests you can do? And when will you do this test?
Second trimester at around 15 weeks.
Okay.
We have biochemical test and UST. Biochemical test include AFP, which is decrease beta HCG and East trial and
There are quadruple test. That's called quadruple test. So what will happen to the beta HCG?
Beta HCG will increase. Inhibin also increase.
Inhibin is also.
Estriol and maternal serum AFP will decrease.
Okay. Yes, very good. So what is the sensitivity and false positivity? Is it better? I already told you. Sensitivity is slightly lower when compared to the first trimester tests, screening tests. Okay. So what are the other tests you can do? Is there any combining of this test? It's called combined test. Can you combine this test to increase the sensitivity? Okay. What are they?
That is pregnancy associated plasma protein A with nuclear translucency with the quadruple test.
What is that called?
Fully integrated test.
Integrated test. Okay, very good. Fully integrated test. Okay. And if you are using serum alone, it is a serum integrated test. Fully integrated test, you are adding nuclear translucency also. So there is got a higher sensitivity rate. That is around 97%. Okay. Then any other test, any other integrated combined test? Any other name? Any others? There are sequential tests also, right? What are sequential tests? I'll show you. What are the sequential tests? There are two types of sequential tests. One is stepwise sequential test, where you are disclosing the results after the first screening. Okay, first trimester screening. And if the risk is very high, they offer the definitive test, and all others will complete the second trimester test. In contingent sequential test, only high risks are further tested. Okay, that is the difference between this stepwise and contingent sequential. Okay, so these are the two combined tests, integrated test and sequential tests. Okay, so if the screen is positive, you offer a definitive test. More than 1 in 250 chance, you offer a definitive test. So what are the definitive tests?
In first trimester, we have chorionic villus sampling. In second trimester, we can amniocentesis.
Yes.
And other tests like quantitative fluorescence PCR.
Yes, this can be done. Okay. If you chorionic villus sampling in the first trimester, after 11 weeks, you can do 11 to 13 weeks, you can do the CVS. Amniocentesis is usually done after 15 weeks. Okay, 16 to 20 weeks, that is the timing. And you can do the karyotyping or FISH or quantitative fluorescence PCR also can be done. FISH and PCR can easily, the turnaround time is within 24 to 48 hours, you can get the result. But karyotyping is mandatory because you should be seeing the structure also. Translocation, otherwise it will be missed. Okay. So what about the cell-free DNA? Can you tell me something about cell-free DNA? Which is being increasingly used now.
That is a blood test that screens for certain chromosomal conditions. It's a non-invasive prenatal screening test.
So when will you do the screening?
10 weeks of pregnancy.
Usually after 10 weeks. Okay. Even though it appears around 5 weeks, it usually the level is usually achieved by only 10 weeks. Okay. There is a minimum level. Fraction should be there to get a positivity rate. Okay. So what are the other advantages? Is it a screening test or a diagnostic test?
It is only screening test.
Yes, it's only a screening test. So even if cell-free DNA is positive, you have to go for a definitive test. So basically, it can be used as a secondary screening also. Suppose if the first trimester test is done using biochemical tests are used, then you can even use a secondary screening method. Okay, secondary screening with the cell-free DNA. So before going to the definitive test, that also sometimes are used. Some centers are using. Okay. So, and the cost is also very much reduced nowadays. It's around 7,500, around 7,500, I think, for the cell-free DNA actually. So, what are the other advantages?
It can also identify other trisomes like adverse screening.
It can detect other aneuploidies and other copy number variations also. Autosomal as well as S-chromosomal aneuploidies also can be detected. Okay. And also here you can have false positive and false negative results also can occur. How false positive results can occur in a cell-free DNA? Actually, it is a cell-free fraction which is derived from the syncytial trophoblast. Okay, from the apoptotic placental syncytial trophoblast, which reflects the fetal cells actually. So how can you get a false positive result then? A false negative also? Which condition you can get a false positive cell-free DNA result? Even though the fetus is not affected, still you can get a positive test in a cell-free DNA. Is there any way? Any answers? Priya, any answers in the chat box?
No, sir.
Okay. So one condition called confined placental mosaicism, where you can have different cell lines. Okay. There is a discordance between the fetus as well as the placenta. In that situation, you can have a false positive result. Sometimes also you can have a early fetal demise or a vanishing twin syndrome. The trisomic twin dies, but that cell-free DNA can circulate for a longer time. Almost 3 months it can circulate. So in that case also you can get a false positive result. In some maternal malignancies, sometimes even with fibroid you can get sometimes false positive results. False negative also same. You can placental mosaicism also you can get false negative results also. So that should be kept in mind. Still, it has a sensitivity of more than 99.5, and a false negative or false positive rate is less than 0.1. So that can be used upfront if you have money. Okay. That is regarding the this thing. So now we are moving on to 2 complications of Down syndrome. So this 10-day-old baby with Down syndrome presented with vesicular skin rash on the face, hepatosplenomegaly, and ascites. Blood investigation showed TC, the total count of 1.2 lakhs with numerous blast and elevated liver enzymes. So who is going to answer the questions? Is the remaining PGs? Anybody else? Anjali, Jose, any Nikhil?
Transient myeloproliferative disease.
Nikhil. So what is the most likely diagnosis here? You're seeing blast in
Leukemia.
a Down syndrome. Yes. What is the diagnosis?
AML.
AML, acute myeloid leukemia. Any other answers? Nikhil? Kavya? Any other answers? Any other
In the
answers?
chat box, they have given transient myeloproliferative disorder.
Myeloproliferative disorder.
Yeah, transient myeloproliferative disease. What is the terminology, the latest terminology for that? Transient TMD is a old terminology. TAM, that is transient abnormal myelopoiesis. Okay, TAM, transient abnormal myelopoiesis. That is the diagnosis. So you cannot diagnose acute myeloid leukemia before 3 months. Okay, so before 3 months, it's if you see blast, it is TAM. First diagnosis should be TAM. And transient, myeloid leukemia usually comes after 3 months only. Okay, up to 4 years or even up to 6 years, you can get myeloid leukemia. Okay, it's called MLDS, myeloid leukemia of Down syndrome. So what are the complications? So what are the other pointers to make a diagnosis of TAM apart from this age? Any other criteria to make a TAM? So you have to demonstrate it is a Down syndrome. So karyotyping is a must. Okay, you have to prove that it is a Down syndrome. Then any other? You have to demonstrate the blast in the peripheral smear. And also there is no actual cutoff for the blast to say TAM. WHO doesn't give any cutoff. So any number of blast can indicate transient myelopoiesis. Then
GATA1 gene mutation.
That is the other test. Okay. And also mutation. You can do the GATA1 mutation also. That is not mandatory to diagnose TAM, but if it is done, it is diagnostic. Okay. So what are the complications that you can get in transient abnormal myelopoiesis or TAM in this situation?
Increased risk of acute megakaryoblast leukemia.
That is later, actually. Immediate risk. This TAM is transient, actually. Transient abnormal myelopoiesis. So it is transient, usually subside by around 2 months. Okay. Maximum 3 months, not beyond that. So still you can have complications. What are they? Which indicates which treatment is indicated. One is hyperleukocytosis, as given in the scenario itself. It is TC is more than 1 lakh. That can cause stasis and can cause respiratory distress, and even tumor lysis syndrome can cause. Okay, so that is very important. DAC can cause, liver failure can cause, liver fibrosis can occur. Actually, it is one of the very poor prognostic factor, liver fibrosis. Then effusions can occur, like pericardial effusions, pleural effusions can occur. So these are the complications that can be expected. Okay. So the third question, what genetic testing? You already mentioned that in addition to
GATA1 gene mutation.
GATA1 mutation. Okay, GATA1 mutations can be done. and that can be diagnosed, but not always it is not needed actually. Okay. What is the role of a bone marrow examination here? Will you do a bone marrow examination here as a part of management? So what is the source of blast here? Anyone? Where is the source? What is the source of blast in transient abnormal myelopoiesis? It's actually from the liver. It is not from the bone marrow. Actually, it is the fetal erythropoiesis. Fetal erythropoiesis is actually taking place in the erythropoiesis as well as myelopoiesis taking place in the liver actually in fetus. So basically the blasts are derived from the fetal liver. So bone marrow is usually not indicated actually. Bone marrow examination is not usually indicated. Okay. So any treatment, what is the treatment option you have? So suppose what are the indications for treatment and what are the treatment options? When will you start treatment for a transient abnormal myelopoiesis? Because there is a risk of early death in TAM also. Almost 20% can have death. So these complications.
There are complications.
Yeah, these are the complications again are indications like what are the complications we mentioned? Hyperleukocytosis more than 1 lakh.
Bleeding, DIC,
DIC,
failure.
then effusions, cardiac failure, then liver. Isolated hepatomegaly is not an indication, but hepatomegaly with liver failure is an indication actually. So liver failure means the bilirubin level more than 10 times and the transaminase more than 20 times. That is the definition for liver failure in TAM. Okay, so that is also indication for starting treatment. What treatment will you start? Actually, this
chemotherapies.
is very sensitive actually. These myeloblasts are very sensitive to chemotherapy. And what is the drug of choice? Usually that is given.
Cytarabine.
Okay. Cytarabine that is given for a short course, usually 5 to 7 days. That is enough. There is a treatment. Okay. So what is the prognosis of this condition? TAM? It is not a benign condition actually. So what is the prognosis?
Most of the babies resolve on their wounds.
Yeah, definitely.
Do not need any
Babies will
treatment.
resolve, but around 20%, as I mentioned,
20% can develop
complications and early death. Okay, and remaining again next 20% can develop AML later. Okay, acute myeloid leukemia later on after after this time period actually. So how will you monitor these babies? What is the protocol for monitoring? To develop whether they are going to develop myeloid leukemia or not. So ideally, you have to repeat CBC and
3 months.
Every 3 months. Okay, every 3 months for 3 years, and every 6 months till 6 years. That is the screening protocol. Okay, so that is regarding the TMP. Okay, transient myeloproliferative, otherwise transient abnormal myelopoiesis. You can see the skin lesions almost looks like a varicella zoster virus infection. Okay, varicella zoster vesicles actually. Vesicular skin rash is again it's not that common. It is seen only in less than 10% of children, babies. So that is again indicates TAM. Okay. So these are the answers actually. So last question. A 7-year-old boy with Down syndrome presented with recent history of neck pain and stiffness, bladder incontinence, and frequent falls. So who is taking up the question? With the last PG? Nikhil, you can try. What is the complication expected in this child? It's a Down syndrome.
Atlantoaxial.
Some neck pain and frequent falls.
Atlantoaxial.
Yes. That is atlantoaxial
dislocation.
Dislocation. Complication is actually dislocation actually. So there is what are these symptoms? Actually, they are the symptoms of myelopathy. Actually, so painful movement of the neck
pain.
stiffness, bladder incontinence. Sometimes there will be stiffness, and there can be frequent falls, hyperreflexia. These are the symptoms of this. So what are the indications for screening in this condition, complications? Is there any routine screening for this complication? Or when will you screen this for complications?
At 3 to 5 years.
Is it routine? Actually, American Academy of Pediatrics does not recommend routine screening. Okay, so screening is indicated only in special situations, actually, because even though there is atlantoaxial instability can occur in almost 10 to 30% of children, the actual dislocation occurs only in 2%. So it's rare, actually. So routine screening is not indicated, but in situations, what are the situations in screening is indicated? Common situations.
Child participating in contact sports.
Yes, those who are involved in contact sports. Okay, that should be regular screen. Okay, otherwise
swimming, driving.
Symptomatic child. Okay, symptomatic child. Clinical signs are the most important clinical predictor of dislocation, actually. So any symptoms you have to screen. That is a must. Okay. What is the third indication for screening? Any other indication? Any surgeries before any surgeries?
Before intubation procedure.
Requiring general anesthesia. Okay, before intubation or requiring GA, you have to screen for the. Why this complication? What is the reason for this complication? What is the mechanism? I'll show you why this mechanism. Okay, so this actually, if you look at the this X-rays, this is actually the dens. Okay, this is the part of the dens, the second vertebrae. This is actually the atlas. Okay, so there is a distance between these two. Okay, here in the flexion, this distance is actually increased. Okay, so this distance, that is the anterior part of the dens to the posterior arch of the atlas, means anterior, the posterior part of the anterior arch of the atlas. This is called, the distance called atlanto-dens interval or atlanto-dens distance, actually. Okay, this distance should not be more than 5 millimeter in a child in flexion. If it is more than 5 millimeter, that means it indicates instability. Okay, so this will be impinging on this space. Okay, this space is actually for spinal cord, actually. So this will compress on the spinal cord, actually. So this is very important. You have to take X-rays in the neutral as well as flexion as well as in extension. Okay, during flexion, this distance is more than 5 millimeter in a child. That indicates there is an instability. Okay, so that is important. So what is the treatment? It is a surgical fusion of surgery. Basically, it is surgery. So when you have symptoms, you have to transport the child after getting a collar and immobilize the neck and straight away send to the orthopedic surgeon or neurosurgeon, whoever is doing the surgery. Okay, so this is an important area you have to. So what are the other conditions where you can have this sort of complication, atlantoaxial dislocation, other than Down syndrome? Shankar sir mentioned one previously. What was that?
Mucopolysaccharidosis.
Yes, Morquio, one of the conditions in Morquio is, you can see. Then
skeletal dysplasias,
like spondyloepiphyseal dysplasia. Okay, achondroplasia. Then other conditions like Marfan's, Ehlers-Danlos syndrome, connective tissue disorders, you can have this complication because of the ligamentous laxity. Okay. Okay, I think we can stop here. It's already 9:30.
Gireesh,
Yeah.
Sankar poyo. Sankar is there. Riyas is there. ഇല്ല തോന്നല്ലേ. It was an excellent discussion. I enjoyed all the thing. I think in the pedigree chart we should have included a gonadal mutation.
Gonadal mosaicism.
Gonadal mosaicism is one situation. Sometimes, rarely, it can also come. Actually, all these
Down syndrome also, sir, there is a description of gonadal mosaicism. If you have two children, two consecutive children with Down syndrome, always suspect gonadal mosaicism. Again, the recurrence chance is more than 10% actually in that situation. That is also very important.
difficult to answer. The importance is that all these questions discussed is much more useful for the DNB candidates. All the MD candidates need to be giving importance to the two stations where the manned stations are. With these sessions, the manned stations actually are not much covered. So DNB candidates, most of the questions will be like this. It will be very, very useful for them. And a special comment about the postgraduates, all of you presented, all of you answered very well. So there's something, that is a commendable performance.
Yes, yes. They are answered very well actually.
Very, very good performance.
Even without any hints.
Really very tough to answer all the genetic testing and all. It's very difficult ones. So Riyas, just you're the final comments, Riyas.
Hello. Sorry. അല്ല സാറ് പറഞ്ഞ പോലെ തന്നെ participation was very good. Sessions there was now I think that stage we have overcome. There was good participation, and as I told, I think genetics is a very pet subject for our students also. They read it up. That is.
Okay, we'll call it a day. But thank you. This is an exhaustive session, more than 2 hours.
Yeah. Good night, sir. Good night.
That's a thing.
ഞാൻ ത്രൂഔട്ട് ഉണ്ടായിരുന്നു, ഡ്രൈവ് ചെയ്യായിരുന്നു, അതുകൊണ്ട്
So how can we some suggestion for man, some
കേട്ടില്ല. റിയസ ബ്രോക്കൺ. റിയസേ പറഞ്ഞ കേട്ടിട്ടില്ല. I think a few questions would have been added for the man sessions also, but it may not be feasible in the online mode.
Yes, sir.
Okay. Okay, we'll call
Sir,
it.
All the faculties done a wonderful job, sir. Thanking them from the IAP Kozhikode.
Okay. Good night.
Sir's contribution also. Okay, sir. Good night.
Good night all. Bye.